issue of intimate partner violence is one that is approached from many different perspectives, and because of that, the definition varies. But increasingly, people are coming to realize that it's not only physical abuse or sexual abuse, but it also includes emotional abuse, financial abuse, so really the broad range of types of abuse that occur within the context of an intimate relationship. Certainly we know that exposure to intimate partner violence is associated with physical problems. So for example, pain, it's associated with emotional problems, depression and anxiety disorders, as well as relationship problems, which are important in health. Gender has everything to do with intimate partner violence, in that we need to look at how gender affects its occurrence, what some people refer to as the epidemiology of intimate partner violence, and we need to understand how gender affects the impairment associated with intimate partner violence. And it's through understanding that type of information that will lead us to developing effective approaches to prevention as well as other types of intervention. We know that those who are in vulnerable situations or where there is a power differential are more at risk for partner violence. So, for example, we know that being in a situation of low socioeconomic status puts one more at risk for exposure to partner violence. We also know that what happens earlier in life is important. So those who've experienced child maltreatment, which includes physical abuse, sexual abuse, neglect, emotional abuse, and exposure to intimate partner violence in childhood increases the risk for exposure to partner violence in later life. At this stage, there is some evidence that advocacy programs can assist women who've been exposed to partner violence. The evidence is not strong, but there is some indication that with a particular kind of advocacy program where women are assisted in accessing services, so for example, to meet their legal needs, their housing needs, these kinds of issues, that can lead to improved quality of life. What's much more difficult to ascertain is to what extent do those problems prevent further violence in the future. Some of the most detailed information comes from work that we've done supported by CIHR, where, for example, we've looked at what we refer to as the 1-year prevalence of violence experienced by women. It's quite notable that in women presenting to emergency departments, it's as high as 14%, which, if you think about it, that's really an important health problem to identify. Our research focuses on understanding the distribution and the determinants of violence, both in terms of child maltreatment and intimate partner violence. Some of the work that we've carried out has shown, for example, that women exposed to violence have high rates of depression and anxiety. And I think that that's important for clinicians to recognize. We're actually developing an intervention to try and reduce partner violence that we are embedding in an evidence-based home visitation program, which has been shown in the US in 3 randomized controlled trials to reduce children's exposure to partner violence. It's a multi-center study that involves colleagues from West Virginia University, the University of Colorado, the University of Western Ontario, Ohio State University, and we are going to conduct a randomized trial where we compare their existing nurse home visitation program to an enhanced model that includes that intervention to try and reduce partner violence. And if it worked in that setting, we're very excited that perhaps the information from that, the benefits from that, could be translated to other types of setting. When we were conducting research on intimate partner violence, which involved speaking with clinicians at different sites, we were struck by the fact that a number of people said to us, I didn't get much education around this. So that led us to apply for a grant to then explore the issue across the province of Ontario of how often is intimate partner violence addressed in the curriculum of health professionals. And we were struck by the fact that very few programs included this. Certainly nursing included it more often than the other professions, but as well, very few hours were devoted to the issue of intimate partner violence. And so one of our recommendations is that intimate partner violence needs to be incorporated into the curricula of health professionals, and that we can't expect that health professionals, after finishing their formal education, are going to feel comfortable addressing these issues if they don't have the opportunity to discuss it, to develop ways of responding to individuals who've experienced it. If they don't get that opportunity during, for example, medical school or their training in physiotherapy or nursing or whatever the health profession we're discussing.